Okay, hi, I'm Shantae Gagnon, and I am presenting on lifestyle modifications and pharmacologic interventions for the treatment of gestational diabetes mellitus. So, what is gestational diabetes mellitus? I will refer to this either as gestational diabetes or GDM throughout the presentation. So, gestational diabetes mellitus is when a carbohydrate intolerance develops during pregnancy, causing diabetes. It's a common medical condition of pregnancy, and it affects around 9% of pregnancies, according to ACOG. White women have the lowest prevalence, and Hispanic, African American, Native American, Asian, and Pacific Islander women have the highest prevalence of GDM. Gestational diabetes is further classified into two classes. We have class A1 GDM, which refers to diet-controlled gestational diabetes. And then we have class A2 GDM, which refers to medication-controlled gestational diabetes. So these are individuals who have attempted to control their diabetes with diet, lifestyle interventions, exercise, which is totally possible. But the blood glucose levels still aren't quite controlled as much as we'd like them for safety and health. So then they need to go on medications to achieve that euglycemia that we want them to achieve, especially during their pregnancy, because gestational diabetes places the mother and fetus at risk for short and long-term complications. So these complications include, they're not limited to birth complications, macrosomia, neonatal hypoglycemia. This is because the fetus is used to being exposed to high levels of glucose and then secreting lots of insulin. Then once the baby is born, the baby's body is still secreting lots of insulin, but it's no longer being exposed to that high maternal glucose. So now it goes to a state of hypoglycemia. So something to watch for whenever your patients with GDM deliver, especially if it's uncontrolled. And then neonatal hyperbilirubinemia, shoulder dystocia, and stillbirth. And then maternally increased risk for preeclampsia, the need for cesarean delivery, developing type 2 diabetes after pregnancy. And then some studies are even showing that fetuses of mothers with gestational diabetes are at increased risk of developing childhood and adult onset diabetes mellitus. So some risk factors, short and long term, that can be life-threatening. And so we really need to, find diabetes if it is in pregnancy and do our best to control it. So let's talk about the pathophysiology of gestational diabetes. So first we need to understand the normal physiology and maternal changes that occur during pregnancy. So during pregnancy, a normal and expected level of insulin resistance occurs to facilitate proper fetal nutrition. During the first half of pregnancy, maternal metabolism is considered to be in an anabolic state, where the mother stores extra adipose to be used later on in the pregnancy. During the second trimester, a shift from an anabolic state to a catabolic state occurs in order to provide the fetus with adequate carbohydrate intake. And this is necessary because the fetus, for lack of a better term, is not a parasite. So it's not going to steal from the mother nutrients if the mother is not getting, the adequate nutrition for herself. Because if mother, doesn't get adequate nutrition and becomes ill or dies, then the fetus will die as well. So it doesn't steal from the mother things that she needs. So it gets like the extra, if you will. So during the second trimester, this shift is necessary to help the fetus get adequate carbohydrate intake, because carbohydrates are a fetus's main source of energy for growth and development. So during the second half of pregnancy, the body naturally acquires a rise in insulin resistance due to a rise in human placental lactogen hormone, as well as a few other hormones. And this allows the glucose to shift to the fetal circulation. And this is normally, a normal and helpful process that helps facilitate healthy development of the baby. But for women who develop GDM, pancreatic beta cells develop a dysfunction and cannot tolerate the increased levels of glucose. So therefore, you develop gestational diabetes mellitus. So let's talk about diagnostic criteria, and with that, the screening. So first and foremost, early pregnancy screening. So in the first trimester, hopefully before 16 weeks at your first prenatal appointment, hopefully, in women who are overweight and have one additional risk factor, which we'll talk about in a little bit, is recommended to screen for pre-gestational diabetes, because if they do have diabetes, we want to help them make lifestyle modifications and possibly initiate medication therapy as needed, just due to all of the increased risks of having uncontrolled diabetes during pregnancy. It's important to control any diabetes that may exist. So we'll do a screening in women who have the risk factors, which we'll go over in early pregnancy. If that screening comes back negative, then you will still screen at 24 to 28 weeks, which is the recommended for every pregnancy across the board, to do a screening at 24 to 28 weeks. So the screening most commonly used is the two-step approach. So this is where we do a 1 hour screening, a 1 hour screening of a woman will intake 50 grams of oral glucose, usually in the form of a drink, but there are a few foods that she can eat. And then an hour later, her blood glucose levels will be tested. And the Carpenter and Kuston values will be used for this presentation today. But the 1 hour screening guideline says the blood sugar levels should be between 130 and 140. So if they're lower than this, she passes and she is cleared from gestational diabetes. Of course, unless later on in pregnancy she develops symptoms. But if the numbers are higher than this 130 to 140, she will then undergo a 3 hour oral glucose tolerance test. So to do this, the pregnant individual will come and get a flat fasting blood glucose level. If that number is 95 or higher, that would be considered meeting or exceeding the threshold. And then she will be given a 3 hour, or excuse me, she will be giving a 100 grams of oral glucose to intake, and then be had the blood sugar tested at 1 hour. The threshold for Carpenter and Kuston at 1 hour is 180. So if it's 180 or higher, that would be considered abnormal. Then again, tested at 2 hours. If it's 155 or higher, that would be considered abnormal. 3 hours, if it's 140 or higher, that would be considered abnormal. And of course, I'm using the word abnormal just for in terms of the reference ranges. And then if the person meets 2 or more thresholds or exceeds them, they are then diagnosed with gestational diabetes mellitus. So here are some risk factors, and a lot of the risk factors for gestational diabetes are actually the same for non-gestational diabetes mellitus. And these are the same risk factors that you would look for in someone based on the recommendations who's overweight and has 1 or more of these risk factors, to do early pregnancy screening before that 24 to 28 week recommended for everyone screening. So physical inactivity, first degree relative who has diabetes mellitus, high-risk race or ethnicity, which I mentioned earlier. Previously given birth to an infant weighing more than 4,000 grams. Previously being diagnosed with gestational diabetes. Hypertension, having an HDL less than 35, PCOS, A1C greater than or equal to 5.7, so having prediabetes, acanthosis nigricans or other insulin-resistant conditions, having a history of cardiovascular disease. Maternal diet can be a risk factor depending on what that diet looks like, and we'll talk about that going forward. And same with exercise habits during pregnancy. That can also be a risk factor depending on what those habits look like, or lack of habits, I guess we could say. And then social determinants of health, different risk factors based on those, which we will talk about more in depth as we go along. So let's start with the basics of dietary intervention for the management of gestational diabetes mellitus. So just a quick review of the macronutrients. Carbohydrates are the non-pregnant person's main source of energy. They're also the fetus's main source of energy. 1 gram of carbohydrates contains 4 calories. Carbohydrates are the macronutrient that raise blood sugar. Simple carbohydrates, these would be things like fruits, vegetables, candy, juice, raise blood sugar more rapidly and more drastically than complex carbohydrates do. The recommended carbohydrate daily intake in general is 50 to 60% of your calories coming from carbohydrates. But this is associated with excess adipose tissue. So for someone who has concerns of excess adipose tissue during pregnancy, that would maybe be a risk factor for, gestational diabetes, or someone who does have both. Having that percentage of total intake be reduced to 33 to 40% of total calories coming from carbohydrates is advised. That helps kind of control both excess adipose tissue and just glucose metabolism. So proteins are the building blocks of cells, and they're important for blood sugar control and our general health. Proteins contain 4 calories per gram, and the recommended percentage of daily calories that should come from protein during pregnancy is 10 to 35%. Animal proteins, so meat, fish, anything that comes from animals, so eggs, dairy, things like that, are considered complete proteins because they contain all essential amino acids. And then plant proteins are not complete proteins in general. There's a few exceptions, but mostly they don't contain all essential amino acids. And it's important to get all essential amino acids, especially during pregnancy, so that we can have, proper development of cells, as proteins are the building blocks of cells and amino acids are the building blocks of proteins. So if someone, let's say, is vegan or vegetarian, or just doesn't like to eat that much meat, they can combine their plant-based proteins to achieve a complete protein in one meal. This example isn't the best because it would most likely raise your blood sugar pretty high for someone with gestational diabetes, but like combining brown rice and beans, both of those are incomplete proteins, but they have the opposite essential amino acids. So when you combine them, you would get all amino acids. So that's an example of how you could do that for people with different diets and preferences. And then fat is a critical macronutrient for hormone production, which is very important, especially during pregnancy and especially for just female health and well-being. And very important for cellular repair and building. 1 gram of fat contains 9 calories. So fats are more calorie dense per gram, but they have so many health benefits, and being calorie dense is not a bad thing in and of itself. The recommended percentage of calories that should come from fat in a day during pregnancy is 20 to 40% of calories being fat calories. So macronutrient utilization during pregnancy. So as I mentioned before, a non-pregnant person's main source of energy is carbohydrates. That's kind of their main function. But during pregnancy, proteins and fats become the main source of energy for the mother. And then the fetus is main source of energy is carbohydrates. Energy needs and changes during pregnancy. So these change each trimester. Maternal metabolism shifts, as we've discussed, and then also just fetal growth and development that will need an increase in calories per day from the mother. So the general guidelines for trimester specific changes during pregnancy during the first trimester is to add an additional 0 to 100 calories per day. That's not that much. So you could give your patients a reference of like 1 apple and maybe a little peanut butter with it, extra to what they've already eaten. So not that much. During the second trimester, it's recommended to add 340 calories per day. And then during the third trimester, and if they are breastfeeding during the postpartum period, it's recommended to add 530 calories per day. So breastfeeding burns a lot of calories and requires increased energy. So breastfeeding, they would still need to have that 530 extra calories. If they don't breastfeed, then technically they wouldn't need that increase in calories, just so that they know that. Okay, so let's talk about some social determinants of health and how this might affect proper nutrition during pregnancy. So this article by Dagger and Linares, it's in the references, but it discusses social determinants of health that impact maternal and infant mortality rates in the United States. These social determinants of health were studied by a critical review of maternal and infant mortality literature. The literature was assessed for factors that led to maternal and infant mortality, and these factors were then assessed for association with social determinants of health. So race, with the most impacted being Black, ethnicity, Hispanic, and then lack of health insurance, lower education level, unmarried status, intimate partner violence, racial residential segregation, low income, and rural residency were found to be the social determinants of health that were associated with maternal and infant mortality. It also discussed the impact of structural racism and how that has an impact on many social determinants of health. And if you're interested in this article, it's very helpful because it gives the women's health nurse practitioner or nurse midwife social determinants of health to be aware of when assessing patient needs and the patient's ability to adhere to management plans. So being aware of patient needs is critical if providers desire to help patients adhere to their treatment plan effectively. So specifically for nutrition, a few social determinants of health to consider right off the bat are, do they have access to healthy food near where they live? Do they live in a food desert? Do they have transportation to a grocery store that has healthy food? Is it too far away for them to walk? Maybe they don't have a car or a way to get there. And then do they have income to afford healthy foods? It's really easy to see that healthy foods cost more than processed foods or less healthy foods do, which is unfortunate, but just kind of the reality of things. So, maybe can they afford to buy healthy foods every week? And then what's their education level as far as their knowledge of nutrition goes? There are so many nutrition myths out there that people fully believe that just aren't true. So what do they know about proper nutrition? Maybe what education can we do while they're in a visit with us? And then do they have time to prepare meals? What's their work schedule, other responsibilities in life? Taking time to cook meals and healthy food is actually kind of time demanding. So maybe for some patients, they would rather just stop by McDonald's on their way to work and grab some breakfast because they're too tired to wake up and make a breakfast, or they get home from work and they're too tired to make a dinner. So really assessing that and their needs that way. You could discuss food prep skills, maybe find ways where they can cook less but still eat healthy foods, things like that. And then when counseling patients about nutrition, especially during pregnancy, it's important to ask them questions that give you a picture of what social determinants of health they live with. Find out where they are starting at nutritionally, and then practice shared decision-making to come up with a doable, non-overwhelming solution and plan to integrate healthier foods into their diet. So I know of a physician who does a great job at this. So he finds out what his patients' diet patterns look like. And then he simply asks them to make one small change at a time. So let's say he has a patient who consumes a lot of sugar. For the first week, he has them focus on, instead of eating a Snickers bar every day after lunch, they just replace it with like an orange. Baby step. An orange has really important phytonutrients and vitamins and minerals. It is a simple sugar still, but it's healthier than a Snickers bar. So for that week, they keep their diet the same, except for that one Snickers bar they change out with an orange every day. And then once they feel good at that, they add in another step to adding healthier foods into their diet. And these small changes that can help the patient cope with the new dietary lifestyle in a way that isn't overwhelming and will lead to long-term adherence. So now let's talk about recommendations for dietary intervention and patient outcomes. So it's been suggested that lifestyle modification alone, diet and exercise, is sufficient to control blood glucose. It's been found to be that way in 70 to 85% of the women who have been diagnosed with gestational diabetes. And then this is just another important note. The recommended weight gain during pregnancy in women with GDM is the same as someone who does not have GDM. So just making sure that the fetus is growing appropriately, and we don't need to come down with stricter weight gain criteria on anyone with GDM. So for all pregnant individuals, a minimum of 175 grams a day of carbohydrates is recommended. And then increased amounts should be individualized further based on the patient's lifestyle and metabolic needs. So this might include their basal metabolic rate, their exercise or activity level. Maybe they're very active and they need more than that just for general health and energy needs. And this is where that 33 to 40% of calories comes into play, that may end up being more than 175 grams for some individuals. So if you're unfamiliar with this, there's tons of resources online on how to calculate somebody's daily caloric needs, and then just simple math to divide that by 33 to 40% for carbohydrates. Prioritize starchy foods, legumes, fruits, vegetables, whole grains, fiber, because these take more time and energy to digest, so they don't spike blood sugar as high or as quickly as simple sugars like fruits, candies, or juices do. Vegetables and other foods with high fiber also help to reduce that spike in blood sugar because they form sort of a like gelatinous material during digestion, which slows down the digestion of the carbohydrates consumed after them and kind of keeps that more leveled instead of a spike. The American Diabetes Association recommends a minimum of 28 grams of fiber a day for women with gestational diabetes mellitus. These fiber recommendations can be met by eating 600 grams of fruits and vegetable a day, and making sure at least half of that, so 300 grams, comes from vegetables with a focus on rough and fibrous vegetables. And then things like wholemeal bread, pasta, and rice will have more fiber in them. And then recommended to have patients distribute their carbohydrates evenly throughout the day, except for at breakfast time. So the reason for this is because in the morning when we wake up, our cortisol and epinephrine hormone levels are higher. Those are our wake up hormones. So they're higher to help us wake up. And these hormones, when they're high in the body, actually cause blood sugar to increase higher than it would when they're not that high. So if you were to eat 20 grams of carbs in the morning while your cortisol and epinephrine is high, that would spike your blood sugar more than if you had the exact same amount of the exact same food at 3 p.m., just because of that effect the hormone has on the blood sugar levels. So dividing it evenly throughout the day, except at breakfast, can look like, based on 175 grams a day, maybe having 20 grams at breakfast with your other fats and protein. That leaves you with 155 grams. You can divide that by 4 for lunch, a snack, dinner, and a snack. And that leaves you with 40 grams for each. So you eat them evenly throughout the day. And that just helps so that you're not going all day without eating any carbs. And then at 8 p.m., you consume 100 grams of carbs. That's really going to spike your blood sugar and not do well for management of blood sugar levels. So just for a reference of what 40 grams of carbs looks like, and to see how easy it would be to hit that goal, it's equivalent to about 1 cup of rice, 1 cup of cereal, a large banana, or 1 serving of spaghetti noodles. So you could easily have a well-balanced meal or snack with 40 grams of carbs or more, depending on what your allotment is. And if patients want to divide that further into like six meals a day, they could do that, just distributing evenly throughout the day to help keep blood glucose levels more stable. And then we can teach patients how to read food labels and understand how many grams of each macronutrient are in each serving if they're not sure how to do that. So recommendation for protein intake is to have 10 to 35% of caloric intake be from protein, with a minimum of 71 grams a day for each individual, unless they have some kind of condition where they need to be on low protein, of course. But protein is very important for pregnancy, for development of both maternal and fetal structures. So really teaching patients to prioritize that protein is important. And then protein studies are showing that if you consume protein first before your carbohydrates, or before your meal, like maybe you have a protein drink on your way to dinner or something like that, it helps reduce blood sugar spikes. And same with fats. So your order of food should be vegetables, proteins, fats, and then your carbs last. Protein from plants, lean meat, and fish. Having reduced intake of red and processed meat are the best recommendation for treatment of gestational diabetes, and this may improve insulin sensitivity. So fat intake is recommended to be 20 to 40% of total caloric intake. And it's important to remember that proteins and fats are a pregnant person's main source of energy, and they are vital, especially during pregnancy. So be sure to discuss benefits of fat and dispel fat myths, things like fat-free diets. A lot of patients can be scared of fats for fear that they will make them fat, but that's just unfortunate because fat has so many health benefits. So taking the time to educate patients on the benefits and really talk about the differences between saturated and unsaturated fats, and showing our patients how to read food labels if they're unaware, to know what kind of fats are in the food so they can prioritize those unsaturated fats, which are healthier. You can talk about healthy fats, different types of oils, and avocados are a healthy fat, things like that. And then lastly, and probably most surprisingly, research shows that taking a daily probiotic, and it was studied in class A1 GDM individuals, showed significant decreases in fasting plasma glucose levels and fasting plasma insulin levels, and decrease in insulin resistance and maternal weight change. So a double-blinded study comparing a placebo and a probiotic supplement during the second and third trimester in A1 GDM individuals found significant improvement in glucose metabolism. So a daily probiotic can and should absolutely be used as adjunct treatment for gestational diabetes. And hopefully pregnant people are already taking their prenatal vitamins, so they can just take it at the same time. It's an easy way to remember. If they don't want to take a probiotic, or just in addition, other foods that have, probiotics, fermented foods, yogurts, just giving them lists of things like that they can eat. Okay, so now let's talk about exercise intervention. This goes into that class A1 GDM diet, lifestyle. Exercise is a lifestyle intervention. So I have 2 randomized control trials to talk about, but I want to talk about definitions first, just to be clear of what the trials mean. So aerobic exercise is exercise that utilizes oxygen from your current breathing to fuel the body. So walking, running, cycling, swimming, you need more energy. You're going to breathe harder, gives your body more oxygen for more energy. That's aerobic. Resistance exercise makes the muscles work against a weight or a force, and this increases muscle strength and mass. So a really obvious example is weightlifting. Moderate intensity exercise. So this is talking about working hard enough to raise your heart rate and break a sweat. This should be something you can sustain for probably more than 30 minutes. If you can't sustain it for more than 30 minutes, it might be just intense instead of moderately intense. And if it's not raising your heart rate or not making you break a sweat, it's not quite moderate intensity exercise. And then before I move on to the randomized control trial, I want to talk about timing of exercise, which is really important. So it's been proved that exercising after consuming food increases insulin sensitivity and decreases blood glucose. And this is because the muscles need energy to perform the exercises and to recover afterwards. So they recruit more glucose. Their insulin is more sensitive to that glucose because they need it. However, there is a thing called the dawn phenomenon, and this is where exercising between the hours of 4 a.m. and 8 a.m. actually causes a spike in blood glucose. And again, this is most likely due to those awakening hormones, cortisol and epinephrine. However, if this time frame is what's going to work best for the patient to where they're actually going to stick to an exercise routine, they will still have long-term blood glucose benefits from exercising, even if it is in the morning. If it's better for them to exercise in the evening, that's actually even better just due to this dawn phenomenon. But if they need to work out in the morning, it's not something that should restrict them from doing so. Okay, so randomized control trial 1, effects of moderate intensity resistance exercise on blood glucose and pregnancy outcomes in patients with GDM, a randomized control trial. So this is from Chung Hong et al. And in this randomized control trial, the control and experimental group received routine prenatal care, online education, and a personalized diet plan. The experimental group also received a moderate intensity resistance exercise program. The trial concluded that both groups had lower blood glucose levels after the intervention, and that the experimental group's blood glucose levels were lower than the control group levels. So they both had decrease in blood glucose levels, but the group with the moderate intensity resistance training had even better control of blood glucose than the group without it. And then a second RCT, effects of resistance exercise on blood glucose level and pregnancy outcome in patients with gestational diabetes mellitus, really looked at resistance exercise versus aerobic exercise for gestational diabetes. So really trying to figure out which type of exercise is best to recommend to patients for the best control of their diabetes. So this is by Huang et al. And for this trial, the intervention group was given resistance exercise program, and the control group was given an aerobic program. They were both 50 to 60 minutes, 3 times a week for 6 weeks. And then people in both groups had a personalized dietary plan, online education, and school courses for pregnancy. And this trial found that the resistance exercise is more effective for blood glucose control and pregnancy outcome than aerobic exercise in women with GDM. And this can likely be applied as well to non-gestational diabetes, just because one way to explain the results is because resistance exercise training causes muscle growth to a much greater extent than aerobic training does, or another type of training. And resistance training places greater loads on the muscles, which causes them to utilize more glucose during the workout. And then muscles require more energy at rest than fat or other types of tissue. So the more muscle mass you have, the more calories and carbohydrates you're going to burn at rest. So having muscle mass, which is caused by resistance training, actually increases insulin sensitivity and glucose use, which is why it's better for management of gestational diabetes and most likely regular diabetes as well. And just general health management of blood glucose levels. Having more muscle mass helps manage those glucose levels better. So social determinants of health and exercise habits. Income. Do they have access to a gym or exercise equipment? Do they have access to trainers or exercise classes? Their environment, where do they live? Do they have the ability to exercise outside or nearby safely? Do they have room where they live to exercise safely? And then other responsibilities that take up their time, work, family, other things where they're so tired. We all know fatigue really impacts our decision to go out and exercise. Other things might also be conditions like depression. So not impossible to exercise still, but definitely a real barrier to having the motivation to do so. That can be discussed. And then education, knowledge of how to perform exercises and the benefits of exercise. So something you can take time to assess and do some education on with your patients. So recommendations for exercise intervention and patient outcomes for GDM. So based on the RCTs, moderate intensity resistance exercise is optimal for blood glucose levels and insulin sensitivity. And the trials also found improved weight gain, so less weight gain, and blood pressure improvements. And then muscle increases insulin sensitivity, so gaining muscle will help lower insulin resistance. 50 to 60 minutes, 3 times a week. That's what the RCTs did, but it's likely you could divvy that out for what works for the patient. If that's 45 minutes a day, 5 times a week or something like that, whatever works for them, doing that moderate intensity resistance training. So exercise inclusivity. What about patients living in larger bodies or patients who have never exercised before? How can we best make recommendations on exercise for them? So this was a great article that talked about ways to do that, and that's to assess individual perceptions of their barriers and facilitators or things that help them to get an understanding of where our patients are starting at. So give patients individualized plan for exercise initiation based on their situation. If they don't have access to a gym or gym equipment, some alternatives would be resistant bands that can fit in a drawer. They're not very expensive. or objects around the house. They could fill milk cartons up with water and use them as dumbbells. If they have other children, they can do squats with them on their backs, finding objects around the house to add resistance to their exercise. Or let's say people who have never exercised before or living in larger bodies, start off with 10 minutes a day and work your way up until you're able to do 30 or 60 minutes a day. You don't have to be great at it right away. You can start small, and some exercise is better than no exercise. So just meet your patients where they are and help them form plans that are doable and will be beneficial to them. And then know of resources for exercise education, classes, things like that in your community. And you could even offer a basic explanation of resistance exercise moves or workout plans if you feel familiar with that, or finding, people in your community who do focus on pregnancy-related exercise, things that are safe during pregnancy, and having referrals or things like that for them. Okay, so last but not least, let's talk about pharmacological management. So this would be for class A2 gestational diabetes mellitus individuals. The common medications used currently, excuse me, are insulin. And insulin is used because it is great at its job and it does not cross the placenta. So we would use pharmacologic management when patients have done their dietary and exercise interventions. They might probably have helped a little, but their blood sugars still are too high for where we'd like to see them. So insulin is the gold standard, FDA approved for treatment of GDM right now. Metformin is considered an acceptable oral anti-diabetic in pregnancy when insulin is not an option, maybe due to finances, not being able to afford the insulin, maybe not being able to self-administer for some reason, or any other reason where insulin just isn't going to work for the patient, maybe a sensitivity or something like that. Metformin is an acceptable treatment. It has actually been shown to create lower mean glucose levels than insulin, but its effect on long-term fetal outcomes is not known. It has been shown to cross the placenta, and it does expose the fetus to levels similar to maternal blood levels. So if you're going to initiate metformin, you just need to make sure you inform the patient of that fact, and that we don't really know long-term outcomes or risks of metformin, and weigh the risks versus benefits of initiating that. Another oral anti-diabetic that's used is glyburide, and this has been shown to be effective in managing blood glucose in pregnancy, but it's associated with higher rates of maternal preeclampsia. So if they're already at risk for that, maybe not the best option. And then stillbirth. And this is higher risk compared to insulin. It may cross the placenta. Studies are conflicting on whether or not it does. Oral anti-diabetics, metformin and glyburide, are not FDA approved for GDM management, but they're often used off-label for this purpose. So patients just need to be informed of the risks before initiating them, which are risks of crossing the placenta, unknown long-term effects on the fetus, increased risk for preeclampsia and stillbirth. And then in this randomized control trial, pharmacodynamics of glyburide-metformin combo therapy in the treatment of gestational diabetes mellitus. Insulin sensitivity, beta cell responsivity, and disposition index in women with GDM were compared using different types of pharmacological management. And the different pharmacological methods were glyburide monotherapy, so used alone, metformin monotherapy, and then glyburide and metformin combination therapy. And the trial found that a combination therapy was most effective overall. So combination of metformin used to maximize insulin sensitivity, followed by using glyburide to increase beta cell responsivity. And this was found to be the most effective strategy if using oral anti-diabetic methods for management of GDM. So some social determinants of health related to pharmacologic therapy to be aware of. Access to care and then quality of care. So do patients have access to pharmacies, to refills, to, providers who can monitor their diabetes and their need for medications and monitor those medication outcomes? Unfortunately, quality of care is not the same everywhere. So what kind of quality of care are they getting based on where they live or those other social determinants of health that we talked about, things like structural racism, provider bias, where they live, income. Provider bias in this article, they had stated Black women had reported feeling that provider bias about their income, their insurance coverage, or other things led to them receiving inadequate or subpar medical treatment. So that kind of goes into quality of care as well as provider bias. So being aware of provider bias around you and yourself, and then also realizing that income and access to insurance coverage are social determinants of health that affect an individual's ability to adhere to management plans and stay on those medications. And like we said, with insulin ability to self-administer, maybe there's other disabilities or things like that that could affect their adherence to the plan. So recommendations for pharmacologic management. Insulin therapy is the gold standard. This is because it's good at controlling blood glucose levels. It does not cross the placenta, so it's very safe for fetus. This is the only FDA-approved medication for management of gestational diabetes as of now. And then metformin, an oral antidiabetic. This is acceptable if insulin is not an option. And again, these are the official recommendations. But just informing patients that metformin does cross the placenta and exposes the fetus to levels that can be as high as maternal levels, and we don't really know the long-term effects of that. However, risk versus benefits, maybe metformin is the right choice for a specific patient. Glyburide has been shown to be effective, but fetal outcomes really aren't well studied. There's conflicting evidence on whether or not it crosses the placenta. And it does put patients at increased risk for preeclampsia and stillbirth compared to insulin therapy. And then the randomized control trials suggest that if you are going to be initiating oral antidiabetics, combo therapy of metformin and glyburide is best for glucose control and insulin sensitivity. And this is because the combo therapy treats more than one modality of GDM. So that metformin for insulin sensitivity and then the glyburide for the beta cell responsivity. So if you are going to do an off-label use of oral antidiabetics during gestational diabetes, combo therapy has been shown to be the most effective route to go. And then now we have time for questions and answers. And these are my references. Thank you so much.